Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, good night, everybody. So it would be great to meet you all today on the Friday night, 28th of August, 2020, with the webinar titled Innovative Lipid-Lowering Therapies from Clinical Evidence to Pharmacoeconomics. So we will be joined by two speakers today with very exciting topics. First of all, I would like to introduce the two speakers. It's my pleasure and honor to introduce Dr. Awaid al-Shemmari. Dr. Awaid is a dear colleague and friend. He's a consultant interventional cardiologist working at Dr. Sulaiman Al-Habib Hospital, Rayyan branch. Dr. Awaid has an extensive experience in both interventional cardiology and in treatment of cardiac patients, particularly those with dyslipidemia. And he will start first by talking about recent MI patients, closer look in lipid management, a journey to improve cardiovascular outcome in very high-risk patients. Then we'll be followed by our colleague at King Saud University, Dr. Ahmed Al-Ghamdi. Dr. Ahmed, he's an assistant professor of pharmaceutical economics and policy, and he's a College of Pharmacy at King Saud University in Riyadh, Saudi Arabia. So before we start, we will would like to share with you the poll questions, so we get you more, get this session more interactive. Have a poll questions before and after, so we see your insights as audience before hearing these those two talks and after, and see whether there will be any difference in terms of people's opinion. Maybe our friends from the IT can pose the first question. So this is the first one. Which patients population below you consider them extremely high risk with more aggressive lipid lowering therapy needed? A, recent MI post-ACS patients. B, stable cardiovascular patients, cardiovascular disease patients. C, FH, familial hypercholesterolemia patients. And D, peripheral vascular disease. So please go ahead and vote, because we will show you the voting later on. Before I move on, I would like to thank the Saudi Heart Association for hosting this event, and this event is being sponsored by Amgen. Oh, so there are people also answered the question number 2. So first one, the most people voted for A, recent MI post-ACS patients, as the extremely high-risk patients, 55%. Interestingly, there are other people divided among other options, particularly stable cardiovascular disease patients. Remember, the question mentions extremely high risk. So choosing would be really interesting here, comparing the different options. We'll hear Dr. Awaid and what his thoughts about afterwards. Number 2, do you implement the ESC, European Society of Cardiology 2019 lipid guidelines in your daily practice, targeting LDL cholesterol level less than 1.4 millimeter or 55 milligram per deciliter, 4 to 6 weeks follow-up for all of the high-risk patients? 68% voted yes, 32%, so around 1/3 still did not vote. So thinking that this is too aggressive or a little bit difficult to achieve. We'll hear about that later on. Next. So do you consider PCSK9 inhibitor a good value for money or cost effective for very high risk patients who can't achieve their LDL cholesterol targets on maximally tolerated statin dose plus minus ezetimibe? 75% said yes and 25% said no. So Dr. Ahmed Al-Ghamdi, I guess you have a challenge there to convince the 25% of people that this might, they might need to change their answer. Could we know how many people voted? We got some impression of what people think so far. So I would like to move on and give the microphone to Dr. Awaid al-Shemmari with his first talk. Awaid, the mic is yours.
So my presentation is about the recent MI patients, closer look in lipid management in those cohort, and this journey to improve cardiovascular outcome in a very high-risk patients. So I'll start with the case. This was a few weeks ago, 55-year-old gentleman is known to have coronary disease and had PCI to a lady under circumflex on April 2020. First clinic visit post-PCI by 1 month. He was clinically well, and the dose of statin therapy at that time was halved by the treating physician, as the LDL was good as per the patient's saying, and he said he reduced the rosuvastatin from 20 to 10 milligram. In August clinic, he came to another colleague and he was having crescendo angina for 1 week duration. And this is the CAF. They showed the April RCA, and this was deemed to be not significant at that time, but in the on August, look, it's 99%. So progressed markedly in a matter of 4 months. So this patients might go to MI, but thankfully he was recognized by the one of the colleagues, and he mandated to do cardiac cath without stress test, and he did the troponin. Troponin was negative, but this denotes how important is the post-MI patients, how aggressive we should be, especially in patients with revisal disease. This expresses how bad the vascular disease secondary to lipid metabolism. The burden of cardiovascular disease, not only that patients, we are among the highest people who lose healthy years of life among the world. So as shown in this study published in 2011, Saudi Arabia is shining there. And their financial cost burden across the globe. There are 2 examples here. In the United States, the cost is forecasted from 220 to 2030 to be tripled, from 50 billion to more than 800 billion. In addition, in the European Union, also the cost is 196 billion annually from only cardiovascular diseases. So then when we look at from those who died from, generally died from immortality, what are the risk factors of death? So hypercholesterolemia is among the top 10 of causing the death. In an Interheart study where they collected 9 attributable burden of risk factor, and the lipid was in the top of the cardiovascular risk factors. And this is the huge study across the globe by Salim Yusuf. So what we are doing here in Saudi Arabia, this is a snapshot in one of the studies done in Saudi Arabia, and in 250 patients with cardiovascular diseases. Interestingly, we found only 10% of this snapshot had lipid profile available in the chart in the last 12 months. So there is no regular checkup of cardiovascular, the lipid profile in those patients, whether they are the target, or at least to know whether they are taking their medicines or not. So having good lipid profile a year ago does not mean good now, because there are a lot of factors that play a role, especially adherence to medications. Another study looking for prevalence of lipid abnormality in 773 patients with CAD in Saudi Arabia, across the Saudi Arabia, about 4 centers. We found in the ACS patients, the mean LDL is 103 milligram per deciliter. And in CHD patients, the LDL is a little bit lower, but not yet to the target. So we are far behind the targets in the ACS patients. Available therapies are statin, ezetimibe, and PCSK9. And for the sake of our presentation, we're focusing in the PCSK9. This is the LDL particle, and this is the LDL receptor bound together, endocytosis in the liver. Then the LDL is recycled, the LDL destroyed, and the LDL receptor recycled, 200 times recycled. This will give the liver ambient time to clear the LDL, circulating LDL in the body. The PCSK9 is a protein in the liver that binds to the LDL receptor and the LDL complex. This makes the LDL attached to the LDL receptor inside the liver, then it destroyed together. So there's no more LDL receptor in the liver to clear LDL, therefore LDL will increase. So the role of the PCSK9 inhibitor is it's an antibody to the PCSK9. Then this complex prevents this protein to bind to the LDL receptor complex. Then this will give the LDL receptor time to recycle again, and no destructions in the liver. Then it will recycle more than 200 times back to what's originally thought to be. Then therefore it will reduce the LDL. So this is the background of the PCSK9. So the study I'm looking for is the 4-year trial, is 27,500 patients, high-risk patients, stable patients with cardiovascular diseases, prior MI, stroke, or symptomatic PAD. Those patients screen and lipid profile, lipid stabilization, placebo run-in, and they found the LDL still more than 70 milligram per deciliter. Then they were randomized to evolocumab or placebo. Evolocumab is a Repatha 140 every 2 weeks, or 420 every month. And this is the result, is marked reduction of LDL, about 59% over the 3 years. And the primary endpoint was cardiovascular death, MI, stroke, hospitalization for unstable angina, or revascularization. And there is 15% reduction in primary endpoint. And the secondary endpoint, focusing on cardiovascular death, MI, or stroke, still marked reduction in the secondary endpoints. When we dissect the endpoints, we notice that the MI is deriving the maximum benefit of evolocumab compared to placebo, and the confidence interval did not cross way away from the 1 point confidence interval. So 4.4 in evolocumab versus 6.3 in placebo. Therefore, we might think that anyone who will benefit the most of evolocumab are those who had MI, because the maximum reduction is from MI. So we'll discuss this later after we see the Odyssey outcomes. Odyssey is a trial for the Praluent drug, and these are post-ACS patients, and almost the same enrollment, but the difference here, we need to focus in they use evolocumab every 2 weeks in 2 different concentration, 75 or 150. If a patient got the target below the certain points, they adjust the dose or they stop the medications if it is less than the 20 milligram per deciliter. This make this study a little bit challenged by the intention to treat, where the people who got the excellent benefit after Praluent and the reduction of LDL way beyond what they wanted, then they stopped the medicine. This caused probably the contamination of the result when you look at those patients who achieved good LDL. Nevertheless, this study showed almost the same result as the Fourier. Even they focus only on ACS patients in the study. And exactly the primary efficacy endpoint is 15% like for your trial. Now, let's focus on what I'm going to do in this presentation is the focusing in on post-MI patients, recent MI patients. What happened to those thousands of patients? As we said, 4-year trials, 27,000, and among them is 5,000 patients with a recent MI. Recent MI defined by 1 month up to 1 year. If you look here, the baseline characteristics, people with recent MI are a little bit healthier than the remote MI. They are younger, they have less hypertension, less diabetes, less stroke, less PAD. So we presume that the clinical events in this group might be the same as remote or even better, because the baseline characteristics, they are healthier than the remote MI. In spite of that, the incidence of primary endpoint is higher in recent MI. This brings our hypothesis in the beginning that the post-MI patients might represent the highest risk group of patients. The primary endpoint increased by 45%, and secondary endpoint, which is defined by cardiovascular death, MI, or stroke, those are very hard endpoints. Not like admission due to unstable angina, because it might not be unstable angina, but the emergency physician admitted the patient with unstable angina. No, we're looking for harder endpoint in secondary endpoint, and there is more benefit, more risk in a patient with recent MI compared to remote MI. After we know this, so let's see what happened in those patients with recent MI when they got evolocumab. They got better benefit or maximum benefit after evolocumab compared to remote MI. So here, the absolute risk reduction is 3.7% in recent MI compared to 1.1% in remote MI. And if you see here, also the Kaplan-Meier curve is start to separate by almost 6 months. But in a remote MI, after 1.5 years. And the secondary endpoint, the same thing. So earlier benefit and bigger benefit in recent MI compared to remote MI. The 3.2% absolute risk reduction compared to 1.3%. And the relative risk reduction is 25% in recent MI. So if we want to give evolocumab in the first question Dr. Khalid mentioned, it's gonna be to people who got the maximum benefit, who are the recent MI patients. The maximum clinical benefit of evolocumab or PCSK9 derived from MI, as we mentioned earlier. And the patients with recent MI were at higher risk of major cardiovascular events compared to those with remote MI, as clearly shown in this subgroup. Use evolocumab, Prepatha, is associated with greater benefit in a patient with, when used in a patient with recent MI. We're going back to our patient, that patients, if we got the PCSK9, probably would have got more benefit compared to halving the dose of statin, where he got another event in 4 months period.
Thank you very much, Dr. Awad Al-Shamari, for elegant talk and nice update about the evidence regarding this topic, which basically shows that, as you have showed us, that those who are high risk at higher benefit from these PCSK9 agents. The question is why people are still reluctant to use them. One of them is cost, and we'll hear about that from Dr. Ahmed Al-Ghamdi later on. But before we move on, maybe I would like to ask you, how recent is recent? So 4 weeks, 8 weeks? So
I think it depends on the LDL. If a patient comes in ER with MI, then next morning you measured his LDL, the LDL is 6. There's no way to get the LDL less than 1.5 with only use of statin and ezetimibe. It might be, where you might be able to, might be not. So those patients, I would go early on, even in the first day. Another example, if a patient's got the LDL is 3.5, then you start high intensity statin therapy with lifestyle modifications, therapeutic lifestyle. Then the follow-up in 6 weeks LDL, not in 6 months. And those patients get the LDL, make sure that the LDL at the target, otherwise start PCSK9. My problem is not when to start PCSK9. My problem actually is from our colleagues to do the LDL, to be vigilant, to make sure that the LDL is measured to those patients, and talking to the patients with the secondary prevention like hemoglobin A1C, LDL, exercise, diet, medication, dual antiplatelet therapy. All of those are very important. So, but because of busy clinic maybe, and because of the LDL is not something the patients will bring. Usually the patients in diabetic, they will bring the diabetes, neuropathic complications and this and that related to diabetes. But the dyslipidemia, we are the only people who are following that. So we need to be open an eye to make sure that the LDL is measured and the patient is told that this is the target. This is the number you need to work on it.
Certainly. One of the main points that you alluded to is that basically, unlike patients in the private practice, patients in the government usually take 6 to 8 months to see the consultant again after being discharged, which is pity. So it's not only measuring the LDL is being measured months and months after the event. And you just taught us now that time matters, and according to the guidelines, it is a class 1 recommendation to see the patient within 4 to 6 weeks after an event, to look at their lifestyle, not only the LDL, the whole picture. So these people do not come back again with another event or instant restenosis. What do you think, how we can get around this issue in a very busy government practice where we see patients months and months after? Any ideas, any thoughts?
I think upon discharge, patients is given they always ask you before discharge, what should I eat? Doc. So what things that I should do? What can I walk tomorrow? Can I drive tomorrow? So at that point, the patient should be told upon discharge, those are the targets. Target of LDL is this, and this should be measured after 6 weeks from now to make sure that we achieved it. Otherwise,
but patients are being given appointment after 6 months and 8 months. How we can change that?
No, it should be in 6 weeks. It should be how you know that the patient is adherent to dual antiplatelet therapy. Then you lose your it's a failure of your treatment. So you spend thousands of real to do the PCI for MI patients, and you will lose all of that if he developed stent thrombosis in 2 weeks. So you need to make sure that the patient is taking his medicines in a follow-up. So 6 months, the patient will think that this is easy. If he got again, he will get admitted again. It's like a flu or like sinusitis, and he can be fixed with another antibiotic.
Yeah, one of the maybe thoughts that come to my mind is, and some hospitals apply this, is basically prevention clinic where many hospitals, as you know, apply the heart failure management programs and heart failure clinics. Similar to this model, could we apply some sort of a high-risk patient model or prevention kind of prevention clinics, whatever you want to name it? So we put criteria for these, for the patients that can come to these clinics, and they can be even run by fellows or registrars, and they can be covered by a consultant on call or somebody on the consult service from a consultant point of view, and they have very specific targets. Obviously, in the private practice, this is way easier, but in the government, I think we need to come up with innovative solutions to get around this issue. Because as you know, we're kind of chasing our tail by pat ourselves on the back and say, well, we did a great job in the cath lab, and yet you have shown us a very interesting case where patients unfortunately come back and they can come to your colleague, and you never know that that was your patient, and you didn't know that actually he came to the cath lab until he sees you after months and months from the event, and you just came to know that he had another event, unfortunately.
Involve the patient to his management. So make the patient himself understand this is what you need to do. If they know that, hopefully they are the one who's responsible if anything happened that is going to happen to them.
Yeah, this is not even mentioning, I just alluded to the system problem. We didn't even talk about the long list of problems with many of the patients that basically either stop the statin, stops the ezetimibe, they stop exercise, they go back to smoking. So we have to remind everybody to look at the whole lifestyle issue and the compliance of the patient with diet and medications and what have you. Thank you very much, Dr. Awaid Al-Shammari, for a very elegant talk and excellent review of the topic. So let's move on to the next speaker, and Dr. Ahmed Al-Ghamdi now will basically talk to you about the pharmacoeconomics, where we're all convinced about the evidence. We want to give the drug, but people argue that it is, one, it's costly, two, it's a subcutaneous drug, how we're going to convince patients to take this expensive subcutaneous drug, although it is easier to use than others. It's just a needle every 2 weeks, but it's expensive. How we're going to convince the system, the administrators, let alone the doctors, to use such as an upfront expensive drug? Could we actually save more money on the long run from a healthcare system point of view? So maybe you can move on to Dr. Ahmed Al-Ghamdi to talk to us about his cost-effective analysis that was done among a large group with other collaborators as well. Had the pleasure of being involved in this project as well. So without further ado, would like to give the mic to Dr. Ahmed Al-Ghamdi.
Thank you, Dr. Khalid. I hope you can hear me.
Yes, go ahead, please.
Okay. First of all, thank you for the invitation, and I would like to thank the Saudi Heart Association for this opportunity. And I'm going to talk in the next 20 minutes or so about the recent project that we did about the cost-effectiveness analysis of evolocumab in the treatment of dyslipidemia in Saudi Arabia. So this research was done in a partial collaboration with Amgen. These are some of the points I'm going to go through quickly for some basic concepts, but then I'm going to focus on the results of our study. So I believe Dr. Wade mentioned a lot of the background information, but cardiovascular disease, CVDs and mortalities because of CVDs are one of the leading causes of death in Saudi Arabia, especially those related to ASCVDs. Almost 37% of the death is related to this issue. Now, economically, this will put the healthcare system in our country under huge burden and under huge pressure. We all know that resources are limited and the demand is very high, not only for CVD patients, but also for all populations. And this put a huge pressure on the decision makers to make proper decisions about how to allocate resources. And the problem is for CVD, for instance, it consumes a lot of resources, and not only those medication, but all the healthcare services too. It was reported that, or estimated that, the economic burden for CVD in Saudi Arabia would reach almost $10 billion in 2035, which is a huge number, given the fact of our economic issues that we face and all healthcare systems are facing globally. And we know that for dyslipidemia is one of the most important factors that related to those kind of cardiovascular events and death, and in the kingdom especially. And LDL was also a well-documented factor, play a role in that CVD and incidence of acute cardiac event mortality. But luckily, as you all know, that LDL is a modifiable risk factor, and it could be treated, and the lower the LDL, the better that outcome expected. But as you all know, there's still some concerns with those standard therapy or lowering the LDL therapy. We know that statins and other drugs, that they have good success in the treatment or reduction of LDL. However, we still have some kind of other patient population, other people with higher risk who could not reach that clinical goals for reducing the LDL with statins alone. That would ultimately precipitate the problem of mortality and recurrent events and so on. Many patients could reach just a maximally tolerated statin doses. People cannot tolerate it sometimes, and statins will not have any further events, further effects. So people like familial hypercholesterolemia, heterozygous familial hypercholesterolemia, and other high-risk patients. So that's why there was the development of newer drugs, the recent developed drug, which is the group of PCSK9 inhibitors that have been developed recently, and have shown, as Dr. Awaid said and mentioned, they have a good effect in lowering the LDL. And also, importantly, they have a good outcome in reducing those kind of CVD events and mortality in some well-established ASCVD patients. But as you see from the first question, you put about the value and all these concerns, people actually globally, it's not only in Saudi Arabia, a major concern for PCSK9 and newly developed and innovative products, it's about the value, and more specifically about the cost. So before I go further, let me just elaborate for some of you, for the attendees who doesn't know the concept of value. In any healthcare system, when there's a new health technology, which include pharmaceuticals or non-pharmaceuticals, people always, decision makers or payers, think about safety, efficacy, and the quality of these interventions, whatever those kind of technologies or interventions. However, we have that issue like any healthcare system, is that there is a huge economic burden because of the high demand and minimum, limited, I would say, limited resources to cover all the those kind of technologies. We still have one of the issues we have in Saudi Arabia is the high healthcare expenditures. Like many other countries, we have higher percentage of chronic diseases, and we have also more required for better quality of life, in addition to the development of newly innovated pharmaceutical products that show to have the good outcomes, but at the same time, they are expensive and have a high cost. So all these together put the decision maker under the huge pressure. How could I make a decision that I would fund the most important of all the important pharmaceuticals for my population? And that's a challenging question. You cannot bring all the health technologies into your healthcare system because you have a limited budget and you have different patient population. You're not only serving cardiovascular patients, you also have another population, diabetes, oncology, and so on and so forth. So how would you distribute those kind of allocated resources? How those resources will be allocated to all population equally and make good access for those. That's why the economic impact, the economic factor should be considered and start to be taken more seriously by many countries. And now we start to think about in Saudi Arabia. For economics, you have to think about two questions. In any healthcare technology, including pharmaceuticals, does it have a value for our money? Which means, does the outcome claimed worth the amount I should pay for it as compared to what I'm using for a standard of care? Then, if you have determined that that has a value, then you go for another step. Can I afford it based on my budget? So basically, is it acceptable? Does it worth for you? Then, this is what we call the value concept, which means that for a new drug to be funded, to be accepted from you as a payer, you have to make sure that the outcome that being claimed, as compared to your standard of care using, are better, and also worth the amount I'm going to pay for it, because I have those limited resources. So you choose the right thing for the patient at the right cost and the right price. So in order to determine the value, we have what's called pharmacoeconomic evaluation studies. Most importantly, cost effectiveness and cost utility analysis. You have to combine in these studies, the cost and the outcome, link them together, and make sure that for each additional life saved, for each additional mortality to be prevented, for each additional LDL lower by how much percentage, for each additional A1C reduction, I will pay this amount of money. Does it worth or not? So for the case of evolocumab, as a prototype of this group, because many studies in many countries have been conducted to determine the value of evolocumab in their healthcare system. And we all know that different healthcare systems have different patients, have different patient characteristics, different prevalences, different healthcare system characteristics that makes you have different results. So for instance, adding evolocumab to as an add-on to statins, whether or without ezetimibe, and clinically evidence-based CVD patient or heterozygous familial hypercholesterolemia was shown to be cost-effective in the United States and in Spain, for instance. In some countries, like in the United Kingdom or Norway, it was cost-effective in certain population, like heterozygous familial hypercholesterolemia or elderly patients. In some countries, it wasn't cost-effective, like in Japan and Australia. So different results. How can we take the message from these different results? In our Saudi healthcare system, we are undergoing major healthcare transformation, undergoing the 2030 vision. And one of the important things that will be involved in those kind of a lot of programs in the healthcare sector, which is the concept of value. You need to determine, and pharmaceutical companies will be requested to provide an evidence about the value of their pharmaceutical products in order to be considered for a payer. For PCSK9 inhibitors, generally, we don't have any, so far we don't have any kind of study that provide that kind of value for decision makers to make sure that you have a solid economic evaluation to make them make that economic element of the decision making. So that's drive us to make that study, which is the cost effectiveness analysis of evolocumab and the treatment of dyslipidemia in Saudi Arabia. So the aim for the study was to assess the added benefit or the value or the cost effectiveness of evolocumab as an add-on therapy to patients on lipid lowering therapy as compared to only statins or lipid lowering therapy with or without ezetimibe. And we took this study from a public healthcare payer perspective, that means from the governmental perspective, in the Kingdom of Saudi Arabia. So what we did is a base simulation study using patient characteristics from real-world data, from locally published studies for Saudi population. And we took the three patient population in our study, those patients with risk, high risk or very high risk, and those with familial hypercholesterolemia, with those targets of LDL that not reach 70 or 100, and familial hypercholesterolemia. So we focused on those three populations where evolocumab has good evidence and approved use. And what we did is for the patient population, we drive those kind of characteristics for our patient from several locally published studies like the STAR studies and other local studies, feed our model with those kind of patient characteristics for Saudi population. In addition, for familial hypercholesterolemia heterozygous patients, we use also a study conducted in the Gulf region that gave us this kind of baseline or basic characteristics for those patients. And also we did a local study parallel to this project to get the baseline and LDL levels. So for any economic study, you have what's called the model, and model is important to feed it with your clinical data, with your patient characteristics, the cost information, in order to project the changes for a longer period of time. And we did use a Markov state transition model that's already been published. We adapted that model, and we did make some adjustment to make it suitable for our Saudi healthcare system. And then we fit that model with those patient characteristics, local data, also with those kind of clinical outcomes data from already published literature, in addition to the cost and data, which we got it from a local setting. For any economic study, you have to have like a time horizon, how much you would expect the cost and the outcomes for this analysis. And we did like a lifetime time horizon, again, from a public healthcare perspective, which only tells you that we only took the direct cost, medical cost in our consideration, and also with a discount rate of 3%, because the cost and the outcomes right now are not the cost and outcome going to be for 10 or 15. So we have to discount those kind of costs and outcomes for the future. And we did like in the model cycle for this Markov model was annually for 1 year. Now, on the right side, you would see that those are the states that we used, we think about in the model. It's not the model. This is just, I just put it in a nicer way. This is not the model. It's just the state we use. Patients could have no ACCVD events, or patients could have non-fatal MI or a non-fatal ischemic stroke, which means that they have, it's the time 1 year after the first event, or they could have post-MI or post-IS when they have the subsequent years after the first year. Could be there's a death from CV death or non-CV death, and also we included other ACCVD that less commonly than MI stroke. Patients would move between the model with more way we did the analysis. The outcomes, the clinical data, of course, we got for the evolocumab and others from the 4-year study and other observational studies that we used to feed the model. For the mortality data, we used the WHO life tables for non-cardiovascular death, and also for cardiovascular death, we did also adapted another study from another setting for the Spanish population. We assume to be almost the same as our setting. So what we did, that's assumption, and we tested later. We also did include the treatment discontinuation using the 4-year Kaplan-Meier estimates, and also in order to capture the complete outcomes, we also included what's called the utility, health states utility, which represent the qualitative part of the treatment. We have that in each treatment, we have the quantitative part, which is the amount of life years saved, and also the clinical data, but also we have in economics what's called the qualitative part. How would you quantify the qualitative outcomes of certain treatment, like improving the social, the mental, the physical? How would you quantify them and then combine them together to what we called a quality of adjusted life years? We got those from the United Kingdom estimates because we don't have it in Saudi Arabia. However, we did some kind of adjustment with specific statistical consideration to make it short of life for our institution, for our setting. For the cost, of course, we used a local study or local cost data from different sources. We have the whole cost that for each state, and we did another parallel study with this cost effectiveness analysis to capture the cost of each state in the model, and included the direct medical cost, included the cost of medication, cost of other services, and cost of hospitalization, cost of procedures, cost of lab, and all the direct medical costs were collected from different institutions in Riyadh. Some costs were not available. Like any economic study, you have to make an assumption, like the cost related to cardiovascular death. So an expert opinion was used to have that cost, but also tested in the sensitivity analysis. In the analysis, we have two things, which is called the base case analysis, where you present the total and incremental life years gaining from each treatment arm or for each competitor. And then you have the total incremental qualities or quality of adjusted life years and also the cost. And the main outcome is the incremental cost effectiveness ratio, which is the difference of cost and the difference of outcome and how much you will pay for each additional quality. In addition, we did sensitivity analysis, which is an important tool in any economic evaluation because you have lots of data from outside sources, published literature, We have a lot of assumptions. We have a lot of uncertainty around some estimates. That's in any economic study. So you have to test how robust your results by doing some kind of sensitivity analysis. And we did a deterministic and probabilistic sensitivity analysis. Now, for the willingness to pay, in any economic study for any country that use economic evaluation, they have what's called the willingness to pay or threshold, which means that's a limit. If it's below that limit or below that threshold, this drug has a value. If the ICER level is below that threshold, it's a value. If it's above that level, it doesn't have any value. So for countries that doesn't have willingness to pay like our country, the WHO recommend to have 1 to 3 times the GDP as your threshold. And we used 3 times the GDP for 2019, which is almost 265,000 real as of. So I hope you got the previous slide. Actually, for the results, for the base case analysis, what we found for each group of the patients, those with clinically evident of LDL target 70, and those with LDL target 100, and those with familial hypercholesterolemia of target of 100. We did compare the ICER, the outcomes and the cost and the qualities for each one of them as adding evolocumab as compared to the only status with or without. And we found here, you can see the ICERs we got from for patient with clinically evident or the target of a 70, it's 109,000, which is less than the threshold that we set for our study. For those with a target of 100, the high-risk patients, we got an ICER that is almost 75,000, and more lower ICER was seen with the familial hypercholesterolemia. Of course, you would see that there's an increase in cost as compared to standard alone. However, those costs were offset by other gaining in the quality of adjusted life years for the evolocumab treatment option. Now, we did also the sensitivity analysis, which, as I said, to test the robustness of our results if we change some of the parameters that we used or we assumed in the study. On the right-hand side, you will see what's called a probabilistic sensitivity analysis, and the left side, you will see what we call the deterministic sensitivity analysis. Deterministic sensitivity analysis, we represented in the tornado diagram, which means I take each one of these factors and I see if I change it by specific upper and lower limits, how much of that ICER would be changed. So for instance, we've seen that if the rate of death or the treatment of LDL or ischemic stroke or MI after 1 year, they have been changed, increased or decreased, the ICER would ultimately be ranged from almost 90 to almost 130. But still, all the factors here did not reach that willingness to pay threshold. That means even though if we change, there's some change in those assumptions, of those parameters, our results still robust and cost effective. Interestingly, that the cost by itself did not have that huge impact if we did change it in the sensitivity analysis, because even though the drugs are, the price are high, consider, but that offset by the reduced in hospitalization, for instance, and revascularization for all population, and lower impact of the sensitivity analysis on the patient with high risk and heterozygous. So mean that the results are still robust. And the right side, you will see that in its probabilistic sensitivity analysis, we want to make sure if we change the willingness to pay to a different level, how much of a percentage that our treatment of evolocumab plus the background therapy will still cost effective. And actually in patients with high risk, it reaches that only at 48%, or let's say 66% of the assumed threshold, the evolocumab as an add-on therapy reached that 100% to be cost effective. And the patient with high risk almost reached 48% of the assumed threshold reached to be cost effective. And even at 16% of that threshold, it started to be 100% cost effective in patients with heterozygous. So still results are robust. So the results would indicate that based on our analysis, the drug as an evolocumab has an added value for patients with clinically evident ACCVD and heterozygous familial hypercholesterolemia as an add-on therapy and considered to be cost-effective option. So there are some kind of limitation, of course. We don't have that utility value specific for Saudi Arabia, so we gathered that from national study like in UK. However, we did a lot of adjustment for those utility to capture that characteristics of Saudi population. In addition, there's the latest guideline by the European Society of Cardiology that they did go for further reduction of LDL in their recommendation in some groups. However, we didn't account for that because we don't have enough information data for evolocumab when they have those kind of new changes. So we have to wait. When we have good data, another study should be conducted. But in conclusion, evolocumab is considered to be a cost-effective treatment option and has an added value in Saudi Arabia. And for decision makers, remember those decision makers, they may consider evolocumab as an add-on therapy for patients who need it as a clinically evident ASCVD patient and heterozygous familial hypocholesterolemia in Saudi Arabia. Thinking for future consideration, any changes and the guidelines and data available for new guidelines, in addition for those kind of utility estimates, if it's be available, another updates for the study should be done. Those are my references. I would like to thank you. And
thank you very much, Dr. Ahmed Al-Ghamdi, for a very rigorous and thoughtful analysis and new data that we're looking for to be published in the near future. Now, obviously, there are two PCSK9 inhibitors in the market, the one by Amgen and one by Sanofi, evolocumab and alirocumab. And as far as I know, that they are kind of a similar price. So we're basically talking about a class effect in case somebody asks why only evolocumab, but for that matter, alirocumab is basically similar price, isn't it? So this should this apply also to the other PCSK9 inhibitor?
Not true. Actually, when you do this kind of analysis, there's a lot of factors involved there. Utilities and the outcomes expected could be different for the other drug, as compared to that. The only thing we would concern is the data. Now, if the data is available and expected to be the same between these two, we might consider that. However, if the clinical data and the patient characteristics of those patients, data, in addition to the cost could be the same. I don't know the price of the other drug. However, there should be a
similar price
estimation. Yeah, there should be a good estimation for those using that kind of drug. But overall, for economic evaluation, as a general rule, you cannot generalize the results of one study over another because there's still another different factors, another different models, another different estimates. Maybe I didn't show those in the study, in the model, but because transition probabilities between those kind of states in the model might be different from a drug to drug. So the data is going to govern that to give us a good conclusion. But however, in economic study, you cannot generalize the results of one to another, even though if they have.
Sure, and that shows also, your presentation shows the importance of having our own local data in order to do such very important analysis and to inform the policymakers, because basically when you sit down with the decision makers, they say, well, that was done in UK or in the US, that doesn't necessarily apply to us. So I think this study is very important and very vital to the decision makers. And that also basically transmits another message that don't only look at the upfront cost, look at the whole picture. And you nicely showed us that for this cost-effective analysis, don't only look at the price on the drug, but look at the whole benefit. And as Dr. Uwaid Al-Shamari showed us, you even get more bang for your buck if you look if you go for even the higher risk patients rather than if you have only limited stock in your hospital and you have to choose as a department. One, it's important to know this data that it is cost effective, but if you have only limited stock, you can go for the highest risk patients, and that can really, you get more bang for your buck. So maybe I'll go over quick questions here from our audience. Dr. Imad Mahmoud, thanks for the good lecture. What about female with atherosclerotic disease and PCSK9 inhibitor, especially at childbearing period, so pregnant ladies? So pregnancy, Dr. Uwaid Al-Shamari, is there any data about safety and efficacy of PCSK9 inhibitor in pregnancy?
No data and shouldn't be used.
Should not.
Should not.
And even statin are not safe and teratogenic.
Unless you have a way to take a consent from the baby.
Yeah, I'm not sure about that.
Yeah. We don't advise it. Even the company. I asked them, both of them actually, Sanofi and the Amgen, both of them, they said no, shouldn't be used.
Yeah. Dr. Hazem Al-Barida, if I pronounce his name properly, you know it is very expensive. Not sure whether this is a typo, but it's monthly for life. Based on the above, does it affect, maybe that was a question before Dr. Ahmed Al-Ghamdi presentation. So he's asking, does it affect, its effect deserve this advantage? So Dr. Ahmed Al-Ghamdi, a question to you.
Okay, so if I understand the question very well, it's about the price of the drug. This is expensive.
Yeah, he's saying this is a drug for life, so and it's very expensive.
Yeah, okay. So this is the concern that we always have in economics. When you talk about cost, you're not talking about price. And you mentioned that, Doctor, already. We are talking about the whole thing. The whole cost that could be related to hospitalization, cost of procedures, cost of adverse drug events, cost of future costs could be saved by using a specific drug. Drugs could be expensive, but however, the longer term, a cost saving could be seen because of these highly cost expensive drugs. That's the beauty of economic analysis, that take into concern all these factors into the cost. Now, when it comes to the payer perspective, it depends who's your perspective. Now, for a study, we did a public healthcare perspective for the Saudi government, for instance. If you think about the cost is going to be the limiting factor, then this is an issue that we had a lot for many innovative drugs. Many innovative drugs have been, for example, did not include it in the formularies because it's a price. But if you did a further and thorough economic evaluation, you might see that even with its economic, but highly priced, but on the long term, there will be a lot of savings for the healthcare system. And funds will be allocated toward a specific population or need. Now, if you talk about patient perspective, who's going to pay for that? Of course, this is going to be highly expensive for our patients. For insurance companies, for instance, they need these kind of information because on the long term, there will be more cost saving than just the price, but depend on which perspective you're. Mainly, we're dealing with a governmental perspective. Those are the payers. So they need this information to consider it beyond the price. And that's what we've seen by many healthcare institutions in different countries.
Great, and maybe moving to Dr. Uwaid, how about the private practice? Some people or some practicing physicians, I have seen it in other parts of the world, not sure about your own experience about filling a lot of forms, arguing with the insurance company. This is another major hurdle, and people even start, practicing physicians start losing the battle and saying, you know what, I'm fed up with trying to get all these company or insurance companies approve the drug, and they get fed up. So what's your own experience in your very busy clinician?
Yeah, alhamdulillah, we are not facing this problem. I think the reason is our patients are classes are VIP or class A. That's why the policy allow that. That's why we don't see this. So seldomly we see some people will say, no, for 1 year. So for how long you want to continue that. So we need to just give them a pre-medical report why we are giving this medicine. And at the end of the day, they will give it. So it's not a big issue in my side.
And along this question, there's a question, Dr. Serafi at the IMC, I think from Jeddah, saying that my patient on Repatha every 3 weeks. We know that you give it every 2 weeks, but he's saying he's giving it once every 3 weeks and his LDL is always below 50 milligram per deciliter. So is that okay?
No, so he did not check it in the 3rd week before the next injection. So 2 weeks, it's good, but the path I usually
No, the whole year. He said the whole year is like that. It's always below 50. So the patient is always getting it every 3 weeks.
Yeah, the action is fast and the offset is fast. So after 2 weeks, if usually he measure it after 1 week of the injection, that will be great. But there is a gap of 1 week, he's losing it. So then the effect is not continuous. There's bounces that he don't see it because he did not measure the LDL during these bounces between the 2 weeks, the second week and third week.
Yeah, I guess he's trying to save some money by saying, you know what, it's less than 50 anyway, so I can save one injection. Although you can argue, as you mentioned, that will cause like a zigzag in his LDL measurements. Dr. Khalid Al-Mtairi, do we have angiographic evidence of atherosclerosis regression with PCSK9 inhibitor? If yes, does this regression translate into long-term survival benefits over standard treatment alone, for example, statin? Dr. Away.
There is a study ongoing in OCT, and I have the privilege to meet with the PI one time. He came visit 6 months ago, and he said it is promising data.
Yeah, and I remember even before the clinical results came out from the PCSK9 inhibitor, there is a nice IVUS study published in JAMA that showed actually there is very good angiographic images, and not sure about regression, but at least plaque stabilization by PCSK9 inhibitor, and then the clinical events came out. So bottom line, the results are robust wherever you take any kind of endpoint, whether you take the angiographic or you take the clinical events. Maybe we can take another couple of questions and then we take the poll, and then we end the webinar. Dr. Mahmoud, what about possibility of drug interaction when used in patients using other monoclonal antibodies? That's an interesting question. You know, rheumatology patients, for example, you know, they might take monoclonal antibodies, very famous in the rheumatology field. I didn't think about that before, actually. If somebody takes another monoclonal antibody, not sure. Have you gone through this? Do you know?
No, I have anecdotal evidence of patients, they take rheumatoid arthritis monoclonal antibodies, and they are taking this. I don't know whether there is a interaction or not, but we know there is no clinically important neutralizing antibodies with the available PCSK9.
It's interesting, Dr. Awaid, that I came across one of my patients was a rheumatologist.
Yeah.
And she has FH, familiar hypoxemia, very high LDL, and she did not tolerate statin, multiple statins. So, you know, the definition of statin intolerance is very variable, but one of them is you do not tolerate at least two statins. And clearly you have myalgias and so on. And this lady definitely has statin intolerance. And I spent like 15, 20 minutes counseling her about monoclonal antibody. I'm talking to a rheumatologist, huh? And you know what? She disappeared. She didn't agree. So you imagine that a doctor, rheumatologist, who treat patients with monoclonal antibody and know that these agents are relatively safe, and yet some patients actually surprise you, and this is a patient and a doctor, and yet she was afraid. She was, did you get this?
Yeah, this is science paradox. So even the inventor for one of the chemotherapy for the stomach cancer, when he got the stomach cancer, he refused to take his medicine.
Interesting how we behave as doctors when we get faced with the same issues that we are advising. Huh?
Yeah.
The other question, thank you, Dr. Ahmed Aghandi, for an elegant talk. Dr. Awaid. Dr. Hash something, is it okay to take alternative day therapy for high cholesterol, like tablet rosuvastatin, or it should be taken daily? As a result, how not much difference in the lipid level? I think I've seen, maybe he's referring to the statins. I've seen some physicians giving like a drug holiday, like a 1 day on, 1 day off kind of thing. Do you do that in your practice?
So in the statin therapy is the mainstay treatment for dyslipidemia. We know that. And if the patient's intolerant, despite of all actions and efforts to make sure that they can take the statin. So sometimes I go way beyond that to give the patients a tiny bit dose of any statin, even twice a week. So
Yeah.
just make sure statin is available in the body in those patients who's intolerant. But in general, we should go as aggressive as possible. The high intensity statin therapy in CAD patients, as a cardiologist, always we go that, even if the LDL is excellent. So we just continue high intensity statin therapy.
Yeah.
Every day.
The last comment, and maybe I'm not sure whether it's a question or a comment, Dr. Pavel Jansa, are you familiar with the SCORE and capital letters, risk charts, recalculation for the Kingdom of Saudi Arabia? I believe this tool shows clearly how risky is the Saudi population and can help to make proper cardiovascular risk stratification, and challenging target LDL levels can be tailored even in primary prevention according to EC guidelines. Unfortunately, Dr. Pavel, that in order to recalculate, or what's called recalibration of the well-known scores, like the SCORE in Europe and Framingham and so on, you really need to have not only the percentage or the proportions of diabetes, hypertension, and so on in your country, but also the mortality rate. So that's why we need cohort studies, such as the PURE study, the well-known PURE study by Selim Youssef. I'm the PI of PURE in Saudi Arabia, and Dr. Ahmed Al-Ghamdi data, actually pharmacoeconomic analysis, used PURE as well in this pharmacoeconomic analysis to follow people over a long time to calculate their mortalities and outcome. So unless you have really large cohort studies to calculate your own mortality, you cannot really do this recalibration, because we know of this SCORE or Framingham, because we know that these scoring system, they can either overestimate or underestimate. We have seen that in the Chinese and Japanese and different populations, that you can really be really off in your estimations. We have seen even the pooled equation analysis by the American College of Cardiology, how much criticism it got, because sometimes it overestimates in older people and it underestimates in younger people. And this is even an equation that was invented by the ACC and applied in the United States. And yet a lot of criticism really got into this equation, because it can under and overestimate even the US population, let alone trying to extrapolate the Framingham or the SCORE. Obviously, we have no other basically scoring system use our own self. This is the only, I'm not saying we cannot use it. We should use it, but be aware that it can, we're not sure really from a data point of view and scientific point of view, are these really very accurate, underestimating or overestimating, unless we come up with our own long-term cohort studies. Like what Dr. Ahmad showed us, that really makes a difference when you have your own pharmacoeconomic analysis. And that was a large group of people that got together really to get this out, to really reach to that point. You read data, local data, and sometimes you don't need, you don't have it. You have to use the most relevant data internationally. And then you have the expertise of Dr. Ahmed Al-Ghamdi and his colleagues at the College of Pharmacy to really put their expertise. And I'm very glad to have this expertise in our country to come up really with this analysis. So before finishing, and we have 3 minutes to go, maybe our IT colleagues can put the poll questions again to the voters. So again, the same questions before starting the webinar, we'll put them again. So we can, before we finish, we see how people change their own mind. Maybe if we can put the 3 questions, please, so people can vote, and we give 1 minute. This is the first question. Which patients population below you consider them extremely high risk with more aggressive lipid lowering therapy needed? Dr. Awaid, what, maybe we'll take your opinion before we finish, but people before that, 55% voted to A. Next question. Dr. Awaid, Dr. Ahmed, any thoughts before we take the poll?
For what?
Any thoughts, anything you want to conclude from your side?
Just to not to consider to treat the patients equally. Post-MI patients, not like stable CAD patients, not like patients with peripheral vascular disease and coronary disease, not like patients with carotid artery disease, peripheral vascular disease, and coronary disease. Those are apple and oranges, so they are different. So we should be so aggressive in a patient who has polyvascular disease compared to vascular disease.
So not all coronary artery disease patients are created equally. This is what you're saying. So basically, really have an open eye to people who are extremely high risk versus the low risk. So here you go, Awaid. So we went up from 55 to 77%. So I'm glad. Still people voting for B, yeah? So stable. It looks like these 8%, you need a one-to-one session with them, Dr. Awaid. FH patients are kind of tricky because you can have very high FH patient like homozygous, and you have very low risk heterozygous. So I still vote for A. Don't you agree, Dr. Awaid? Yes. For recent MI post-ACS? Yeah. And do you implement the EEC guidelines, the recent ones, 80%, again, improvement in the percentages? And Dr. Ahmed Al-Ghamdi, it looks like you got a lot of people convinced, 25% went down to 13%. Do you consider PCSK9 inhibitor a good value for money? So still you have people still finding difficult 13% to apply it because of the cost or whatever. So I would like to thank both of you for very thorough and elegant review of the topics, great expertise from both interventional cardiology and very busy practicing physician, Dr. Awaid Al-Shamri, and very thoughtful and new data. These data have not been presented before by Dr. Ahmed Al-Ghamdi and his group from King Saud University, College of Pharmacy at King Saud University. Thank you very much. I hope the audience enjoyed this webinar and benefited. I learned a lot. And thank you very much for the Saudi Heart Association and Amgen for sponsoring the event. Thank you very much for both of you.